I'm going to continue on with chapter 15 and look at alterations in the cognitive systems, cerebral hemodynamics, and motor function. All right, so we'll start off when we talk about alterations in the cognitive systems. Really what we're going to be looking at is consciousness and alterations in consciousness. All right, so consciousness is the state of awareness of oneself and the environment. Right, and we can break this up into kind of two smaller categories, both arousal and awareness. So arousal is the state of awakeness, right, which is one part of consciousness, all right, and awareness, which encompasses all cognitive functions, right? It's our ability to recognize kind of where we are in the environment using our cognitive functions. And so a second part of consciousness is awareness. Some alterations in arousal, they can be structural, right, due to changes in the, specifically in the brain, which is supratentorial, infratentorial, as well, right? A lot of times it has to do with direct destruction or compression of different parts of the pathways that are involved with staying awake. And then metabolic disorders, which basically are a decline in arousal because you're not getting enough energy substrates like glucose or oxygen to the brain, and that can cause decreases in arousal. Psychogenic arousal is pretty rare, but there's unconsciousness, although the person is actually physiological awake and actually responds to a neurological examination. So some clinical manifestations, again, probably the most important manifestation, what you're really going to look for when you're talking about changes in arousal is changes in levels of consciousness, right? A decreased level of consciousness would be implied that the person is less alert, all right? But a person who is alert and oriented to their self and others and time, things like that, is considered to be conscious, all right? And then as these things start to diminish, they say consciousness goes away. One thing that you can notice, or another clinical manifestation that you see with people that have lost or have changes in arousal, post-hyperventilation, apnea, where respirations stop after hyperventilation, has lowered PCO2 to below normal, so basically they stop breathing. We have Shine-Stokes respirations, where essentially the breathing pattern of this person increases in rate and in depth, right? And then it's followed by a gradual decrease in rate and depth to the point of apnea, where basically the person stops and this cycle basically repeats over and over again. All right, we have changes in pupillary reactions, which indicates basically the functioning or dysfunctioning of the brainstem, because the brainstem controls areas that are involved with or control arousal that are adjacent to areas that control the pupils. So we can look at the pupils. If a person's ischemic or hypoxic, they usually have dilated pupils, all right? Hypothermia may cause fixed pupils, right? Inability to change when you shine light on them. Some drugs can change pupils, and it can be used to evaluate comatose states. Right. We have ocular motor responses. All right. So these things change at various levels of brain dysfunction, especially in comatose individuals. All right. Persons metabolically induced coma, except with barbiturate, hypnotic, and phenytoin poisoning are examples of that. All right. So injuries that involve an ocular motor nucleus or nerve cause the eyes to deviate outward. All right. So we can look at the position, right? Literally the position of the eyes. Where are they pointing at, right? It's independent of the pupils. Motor responses are another thing that you can evaluate, the level of the brain, right? Reflexes and things like that. Vomiting, yawning, and hiccups are also an indication of changes in arousal. So brain death, right, related to arousal. So this is a point where we also call it total brain death, when the brain can no longer maintain internal homeostasis. And so for brain death to be diagnosed, these criteria have to be met. So there's completion of all appropriate diagnostic and therapeutic procedures. They have to be in an unresponsive coma, basically the absence of motor and reflex responses, no spontaneous respirations. Pupils are dilated and fixed. They can't change. There's no reflexes. There's a flat electroencephalogram, which basically shows brain activity. And this would last at least 6 to 12 hours after onset. Cerebral death is an irreversible coma, is a death of the cerebral hemispheres. All right. With this, there's no behavioral or environmental responses. However, the brain can continue to maintain internal homeostasis because other parts of the brain, like the brainstem, still do function. And we have alterations in awareness. All right, we're looking a lot of times at memory is a good example of this. They changes in memory, they can be temporary or permanent. We'll go through some examples of both, but when they're temporary, like after a seizure, the person typically regains their memory. However, they can be permanent after a severe head injury or an Alzheimer's disease when the brain really is permanently damaged and it cannot recover. Amnesia, we can break that up. It's a type of loss of memory. So retrograde amnesia is the difficulty retrieving past personal history memories or past factual memories. Anterograde amnesia is the inability to form new memories, personal or factual memories, but you could still retrieve past memories. All right, and then some executive attention deficits. So if there's issues with the frontal or prefrontal cortex, one of the most common ones is attention deficit disorder, right? Which is a person is unable to essentially focus, whether they're at work or at home or in social situations, right? They're often hyperactive, right? And so this can occur both in children and in adults, all right? It's a very complex disorder. Really, what's causing it is unknown. Often stimulants are used actually to treat this disease, think Adderall and Concerta, drugs like that. All right, dementia is the progressive failure of the cerebral functions that include different processes. We often think about a loss of memory, which is true, but there's other things like loss of orientation, right? Inability to use language properly, loss of judgment and decision making. And there's a lot of reasons for this to occur. It could be neurodegeneration. We'll talk about Alzheimer's, that occurs. Brain tissue compression, maybe for an injury. Atherosclerosis, where you have loss of, it causes occluding of arteries up to the brain and no blood gets up there or less blood. Or brain trauma, which could be related to tissue compression. It can also be genetically predisposed. Alzheimer's is one example. All right, so it's often genetic related, so it's early onset familial. All right, there's also non-hereditary, which is just sporadic later onset. So if it occurs early in a person, it's usually related to a hereditary or familiar disease. If it's later on, it's more of a sporadic usually a non-hereditary inherited disease. There's a few theories behind it. There's mutation for encoding amyloid precursor proteins that are in the in the brain, as well as alterations in a protein that carries cholesterol called apolipoprotein E. Ultimately, it basically results in holes in the brain, right? Due to these amyloid plaques that build up and they form these little tangles, all right? And clinical manifestations, there is forgetfulness. The person can get very emotionally and upset, big disorientation, confusion, inability to concentrate, decline in abstraction, problem solving, and judgment. These are typically very severe, very compared to dementia. And so the diagnosis is made by ruling out other causes of dementia that we talked about in the last slide. But you can see here, right, literally there are holes now in the brain, right? And these neurofibrillary tangles, fibrillary tangles are basically, so you can see if you look inside the cytoplasm of that cell of an Alzheimer's brain versus a neuron of a normal cell, where you see these little tangles, and basically these little lines in there are microtubules, right? And you have this basically unregulated, unstable, basically cytoskeleton within these that starts to disintegrate and ultimately can cause the neurons to die. And so the neurons start to die, holes form in the brain, right? And it can affect parts of the brain that are involved with memory, language, and so forth. And you may also have heard it's associated with a protein called tau, the tau protein, right? This is normally associated with normal microtubule function, but basically the tau becomes changed, it becomes hyperphosphorylated, and so the tau protein loses its function, right, ability to function, and microtubules basically start to fall apart. Seizures are another example of an alteration. So again, often they're manifestations of other diseases, but what they are is they're sudden transient alterations of brain function caused by usually abnormal excessive discharges of cortical neurons that fire and send signals when they normally shouldn't. They're basically overactive. So there's epilepsy is a condition where there's recurring seizures. It's thought to be caused by genetic factors as well as maybe some environmental factors. All right, excuse me. A convulsion is a tonic-clonic. It's a jerky, contract, relax movements associated with some seizures where a person basically, their whole body tenses up and then relaxes, whole body tenses up and relaxes. So, some of the illogical factors, there's metabolic disorders that are related, some congenitals, just malformations, genetic predispositions important, right? Other things, infection, brain tumor, vascular disease, substance abuse, often the withdrawal of alcohol for a person that's a severe alcoholic will lead to seizures and ultimately death. So you have to be careful when you're treating an alcoholic patient. So these are just an example of different types of seizures, right? So tonic-clonic we've talked about already. So basically we can break them up into, we'll go back further, seizures into either generalized or partial. All right, so generalized are, they involve both, either start or at least start in or involve both cerebral hemispheres, right? Can impair consciousness. So for instance, tonic-clonic, we've talked about the muscular stiffens and then relaxes, and there's kind of the jerkiness. Atonic, sudden momentary loss of muscle tone, and there's so forth. You can also break them into partial seizures where seizure activity begins and is usually limited to one part, either of the left or the right of the brain. Increased intracranial pressure in the brain can also cause problems with the brain, often caused by some kind of increase in intracranial content. It can be a big tumor that's growing in your brain, right? It can be edema, excessive cerebrospinal fluid, or a hemorrhage in the brain. All can result in increased intracranial pressure. All right, and so here's the different stages of first the brain compensates, right? So early on, there's stage 1 and 2, right? The person's alert and awake, right? Eventually they might have some confusion and restlessness and lethargy. Their pupils in stage 1 are equal and reactive, right? So they haven't changed size, they'll react to light. Breathing is still normal. All right, with stage 2, same thing. During stage 3, the person starts to compensate for this, right? And so they're beginning having an inability to stay awake, right? Eventually they can slip into a coma if the pressure inside of the brain continues to change. And what happens is, right, the pressure starts to go up, right? And so what the brain does is it compensates by getting rid of the normal blood in the blood vessels to try to relieve pressure, right? But now you don't have blood coming to the brain, so the brain starts to essentially not function. So during decompensation with pupils for stage 3, the pupils typically become small. They're still reactive, though progressively getting worse and not responding to light. Breathing may progress to the Shane strokes, all right, eventually as it progresses, right, and then changes in blood pressure, you start to have a higher increase in pulse pressure because you have less blood in the brain and more in the body, and more blood's being pumped by the heart. And then eventually, so for stage 4, we have herniation or decompensation, further decompensation, where things continue to get worse, right? And eventually this will lead to death if due to a loss of blood flow to the brain. Cerebral edema is one example of this. So it's an increase in the fluid, either intracellular or extracellular within the brain. So it can actually be in the neurons if it's intracellular, or it can just be in the interstitial space if it's extracellular. Vasogenic is a type of cerebral edema caused by increased permeability of the capillaries in the brain, right? So usually a loss of the blood-brain barrier. And this is usually the most clinically the most important or the most relevant. Cytotoxic, extracellular water moves out of the cells because of a shift of sodium. For some reason, there's a shift of sodium that can be caused by different things out of the cells, and then the water follows it, so the cells start to shrivel up. Or sorry, the other way around. Water starts to move into the cells, and they can basically lyse or pop. Or interstitial cerebral edema, where there's a movement of cerebrospinal fluid from the ventricles and into the extracellular spaces of the brain. So normally CSF is kind of stored and flows through the ventricles, and it's not in the extracellular spaces of the brain. But when it moves there, it can then put pressure on the brain and the cells themselves. Hydrocephalus is typically associated with infants. So you can see the massive head here on this infant. It's the excess fluid within the cerebroventricles, subarachnoid space. It puts pressure on the brain. It's typically associated with some kind of interference with cerebrospinal fluid, which results in accumulating in the cranium. So it can be decreased reabsorption, an increased fluid production, or just obstruction with moving it around. All right, and now we're moving to some alterations of in neuromuscular function. Right, so often this is related to the brain, but it can also be related to disorders with the actual muscles themselves. So typically it's dysfunction of the cerebral cortex, the pyramidal system, or the extrapyramidal system, right, if it's related to the brain, or it can be to the motor units, which are in the individual muscle units. So some terms to be familiar with that are regarding changes in muscle tone, hypotonia, which is a decreased muscle tone, which ultimately can result in basically too much flexibility of the muscles. All right, hypertonia, which is an increase in muscle tone, ultimately can decrease the flexibility of the muscle. So some alterations in movement. Hyperkinesia is excessive or purposeless movement. We'll come back to this in a little bit. There are diseases that have this as a manifestation. Paroxysmal dyskinesias are abnormal involuntary movements that occur as spasms. Tardive dyskinesia is involuntary movements of the face, lip, tongue, trunk, or extremities. Most commonly, you see them as a side effect of antipsychotic drug therapy, prolonged in particular. Then there's hypokinesia, which can be broken up into the opposite, basically, of hyperkinesia, broken up into akinesia or bradykinesia, which is either the loss or the slowing of movements, respectively. One disease that's somewhat common is Huntington's disease, which is autosomal dominant, right? A hereditary degenerative disorder. It causes severe degeneration of neurons in the basal ganglia, specifically the caudate nucleus and the cerebral cortex. Ultimately, it results in the depletion of a neurotransmitter called GABA, which is gamma-aminobutyric acid. And some of the symptoms of Huntington's disease are uncontrolled movement, some emotional problems, and a loss of thinking ability or cognition. Parkinson's, which is one you're probably more familiar with, it's degeneration of the basal ganglia, in the corpus striatum, which involves basically the destruction of dopaminergic secreting neurons. So if you remember, this is the substantia nigra, which normally produces dopamine. Right, this dopamine is used as a way to inhibit and kind of control emotions. Right, in the case of Parkinson's, we lose that dopamine, and one thing you'll see is there's an inability to control certain movements. We also see we'll come on the next slide, but characteristics of Parkinson's is something called the Parkinsonian tremor, overall rigidity of the body and muscles, bradykinesia, some postural disturbances, autonomic and neuroendocrine symptoms, as well as cognitive affective symptoms. So here, right, some of the things that we talked about already, right, so there's the Parkinson's tremor, right, often associated with a shaking of the head, right? We also see some tremor associated with the hands, called pill rolling, where basically people are constantly rubbing their fingers together. Also short shuffling steps, they kind of drag their feet as they walk. There's also constipation, right? Dysphagia, which is trouble swallowing, drooling, right? Because inability to control facial muscles and some of the muscles associated with swallowing and peristalsis, an unsteady gait, which can be associated with the short shuffling steps, and overall rigidity, right? Kind of tightening of all the muscles in the body. And as a result, we have a kind of a posture where the person's just kind of stooped and bent over just a little bit. Some of the alterations in movements, so moving on, alterations in movement. So we have paralysis, which is related to upper motor neuron syndromes. So some of these are paraplegia and quadriplegia. So paraplegia is a weakness and or a paralysis, meaning the complete loss of movement, typically of the lower extremities, right? So it would be the legs in this case as a result of a lower spinal cord injury. So with a paraplegic, they still have the ability to control their arms, but their lower legs are no longer under the control of the body because the spinal cord injury is below the arms. Quadriplegia is the loss of all four extremities, right? It's an upper spinal cord injury, right? So you lose the ability to control your arms and your legs. So para, 2, quad is all four limbs. ALS, amyotrophic lateral sclerosis, also called Lou Gehrig's disease after the famous Yankee player. He was one of not the first to get it, but the first famous person to get it, which really brought this disease attention. It's a neurodegenerative disorder involving both upper and lower motor neurons, right? Ultimately, basically lose the ability to control your skeletal muscles, and the muscles start to weaken. Its cause is unknown. Again, it starts with the weakness, and then it progresses to atrophy, spasticity, and the loss of manual dexterity and gait, and then inability to breathe is what usually, and control of the diaphragm is what usually ends up being what's the most fatal part of ALS.